welcome. Several individuals are still walking in. We're about 2 minutes ahead of time. But just to remind those of you who happen to be here for the wrong reason, this is session number 48. And we're going to be discussing the shortened regimens for the treatment of multi-drug-resistant tuberculosis. I'm Ken Castro, and this is our tribute. Unfortunately, our colleague was not able to be here.
Because he had not received his visa, was refused.
Yeah. So we acknowledge that he would otherwise would have been here. Each of the 5 presentations is going to be done in 15 minutes. If they're done in time, we will allow 1 clarifying question, but at the end, there's going to be a 15-minute for questions and answers. So if you have questions and there's no opportunity to ask immediately afterwards, please write them down and be ready for the presenters at the end. Okay, it's 1:30. Let's get this show on the road. The first presenter is Dr. Chang. Unfortunately, our man Van Doon is ill. Our thoughts and prayers are with him. But Dr. Chang graciously agreed to give the presentation. I believe that he got the slides from Armand. Take it away.
Yeah. Okay, thank you. Good afternoon, everybody. Armand Doon is not able to be here because he is got something on his face. So he sent his regard to all of you. If you are here to see Armand Doon, you will be disappointed because obviously I'm not Armand Doon. So, but if you're interested in 9 months regimen, perhaps welcome you to stay here. About the 9 months regimen, how it works, we published an articles on the September issue of IJTOD. This title is more on the gartifloxacin. But in that paper, we also explain how the 9 months regimen works. So I would use, the slides are prepared by Armand, and he sent slides to me. I only add 1 slide, and that slide that we discussed a lot, that was studied by Gambo, and it's important to illustrate how the 9 months regimen works. So I add that one. You will know that this is a 9 months regimen. It's 7 drugs to begin with in the intensive phase. The intensive phase is for 4 months, but the intensive phase will be extended. If their smear remain positive at end of 4 months, it will be extended for 1 more month, up to 5. Smear remain positive, then 1 more month. If smear negative at 5 months, then move into the continuation phase. The continuation phase has 4 drugs that include high-dose gartifloxacin, ethambutol, pyrazinamide, and chlorphasmin. So that is basically the regimen that Armand designed. He designed this regimen based on experience in the past that he used together with our colleague from Bangladesh, Damien Foundation, our colleague here, went through the 6 regimens and come up with this one. He did not go slowly from 15 months to 12 months to 9 months because he think if you go slowly, it will take a longer time to see how the 9 months regimen, how the regimen can work. So he moved immediately to 9 months based on this regimen. The consideration that he had is that he hoped that the regimen is being used by the paramedics in low-income countries, so that it can be used like a simple regimen that everybody can use, not to be centralized at the capital or in urban area. Hopefully, the regimen will be well tolerated by patients. So in order to do that, those toxic drugs in the past, group 4 drugs would be used, but would not include more than 2 group 4 drugs in that as the previous classification. Also hope that the regimen is highly effective and robust, and also important, is affordable. At that time, when he used Leukeran and the gartifloxacin at that time already has generic product. So the cost, he told me, was about 220 euro. When you move into moxifloxacin, the price can easily go up to 1,000, 2,000, 3,000 euro. So that is the important point. Then a little bit into the detail. It's a standardized regimen. It's not individualized. And the standardized regimen has a fixed duration with clear drugs in intensive phase and in the continuation phase. The regimen was not designed based on individual susceptibility testing. It was based on resistance prevalence in the population. So if in the countries that has resistance pattern that does not match with the regimen may not work. Like you have a high frequency of quinolone resistance that we will discuss in a few minutes. But it's important to keep in mind that it's not based on individualized regimen. That is the design from the outset. So when I see that people say that, no, if you have resistance to 1 or 2 drugs, the regimen does not work, perhaps that is not entirely correct, right? That is not the design. How can you say that if ethambutol is resistant, then the 9-month regimen does not work? That is not the design, okay? So keep that in mind. And then the design also hope to avoid toxic, little effective, expensive drugs. In the past, the good 4 drugs we have thionamide, prothionamide with cycloserine and PS. And we know that those drugs are causing trouble. 10%, 20% of patients will not be able to tolerate. You need to remove those drugs from the regimen. So he only include 1. And that perhaps is one of the best out of the 3. That is prothionamide. So instead of using those drugs, he combined the first-line drugs and chlorphazimine. We'll come back to chlorphazimine in a few minutes. Reduce the duration of kanamycin so that the toxicity can be reduced and also less likely to create acquired resistance to injectable. Then reduce the duration of treatment, perhaps make it more tolerable for patient and also more easier to complete. So the effectiveness is more important as compared with efficacy when we know that in the MDR-TV treatment, the loss of follow-up is a major issue. And why 9 months? Based on the experience in the past of the ofloxacin regimen, he reduced that to 15 months based on finding from Hong Kong, showing that using 15 months ofloxacin-based regimen in the long-term follow-up, there's very few relapse. So it's overkill. So he got down to 9 months. And why 9 months? Because also based on animal study on moxifloxacin, showing that the sterilizing effect of moxifloxacin is quite good. By 9 months, kind of get rid of all the bacilli, but ofloxacin and levofloxacin was not able to do that. So if you go for levofloxacin, we were concerned that perhaps the duration of treatment would need to be prolonged. Now, let's go to the drugs one by one. Now begin with the core drugs. The core drug is gatifloxacin. In any regimen, what is needed is drugs that has good bactericidal effect to achieve sputum conversion. And also we need drugs that has good sterilizing effect, that it can really get rid of bacilli that to reduce relapse. So the core drug here is, in fact, is quinolone. The quinolone has been shown that has excellent sterilizing effect based on in vitro evidence. And also the MIC, you see the difference between ofloxacin and moxi and gatifloxacin. The MIC are not the same. Then also, what's the reason of this high-dose gatifloxacin? The high-dose gatifloxacin idea comes from a study of Gamble that I'm going to show you. What the reason of using high dose is mainly to prevent amplification of resistance to quinolone. In the Bangladesh experience, you see that in the publication in 2014, there was no amplification of resistance to quinolone at all out of 500 patients. And that may not be the case when we use the normal dose moxifloxacin, 400 milligram. We will need to test this hypothesis using data from countries using normal dose moxifloxacin. But it's important to know that the design of the high dose gatifloxacin was mainly to get rid of mutant. So that is the study that Aman used to rationalize the reason of the high dose moxifloxacin. You can see here is a different, it's difficult to read. The ABCD, the main difference is the ratio of area under the curve and the MIC. So the A has no drugs, and then the D has a very high dose, moxi, like 800 milligrams. So give you a very high ratio of area under the curve and MIC. And there are two. This is the total the burden of bacilli. And so without treatment, you see there's an increase of the burden of the bacilli. And this is the drug-resistant mutant to quinolone. So when there's no treatment, there's no change. You begin to treat. Obviously, we know the fall and rise phenomenon, that susceptible strength would decrease and the total bacilli burden would decrease. But then the resistance strength kind of pop up over time, right? Over time, you see that it increase. You increase the dosage, you also see that the reduction of the total burden of bacilli, but then the mutation, the mutants also kind of pop up at the end. Then finally, when you really push the saline level very high using 800 milligram, you don't see that. So that's the reason why he kind of very keen to insist it's important to use this high-dose moxifloxacin. And so there are two sides of the coin. One is that when you push the saline level very high, you prevent amplification of resistance. But if the patient already have high-level resistance to quinolone, then the regimen does not work. So that is this slide. The slide shows us that if the patient has susceptible to quinolone, or it's only low-level resistance to quinolone, you got a very high success rate. But then if you got high-level resistance to quinolone, then the success rate dropped to 50%. The regimen does not work. So what is really needed is that we need to pick up high-level resistance to quinolone, and we need to include new drugs like betaquinone and tenamidine in the regimen. Now, the second one is kanamycin. In terms of the early bactericidal effect, kanamycin is not as good as quinolone, high-dose quinolone, the fourth-generation quinolone. So kanamycin is, the role of kanamycin is to support quinolone to kill the mutant of quinolone. So it's in the supportive role. It's very little resistance in most countries. It's strong killing initially, but there's no sterilizing effect. So it protects against FQ quinolone resistance. And he said 4 months and extended to smear negative. He tried to reduce that, but then the outcome was not good. So at this point in time, the minimum requirement is 4 months injectable of kanamycin. Chlorphazimine. People wonder why he used chlorphazimine. Armando in the past was also working for leprosy, and you know that chlorphazimine is drug for leprosy. So he based the observation in the lab. He see that in the MIC of the chlorphazimine is quite good of the chlorphazimine to go against tuberculosis bacillus. So he increased that. But you will see that around 2004, 2005, there's discussions on the IJTLD, people questioning why you use chlorphazimine. So there's a lot of discussions on that, and then the evidence at that time when you use it was really not clear, basically based on in vitro study. And then I think our colleague Arnold Tribuk, now sitting here, he decided, I think, with Don Anderson to ask experts to do a study for that. And that is, we have Professor Gosset to do the study. I'm going to walk you through this important study. This is an animal study. So you see that in the beginning, when there was no treatment, you see the log coloniform unit increase. So the burden of bacilli increase. So there are two arms of regimen. One is, the blue one is a control regimen. This is amikacin, moxifloxacin, ethambutol, pyrazinamide for 2 months, followed by 7 months, moxi, ethambutol, and pyrazinamide. The experimental regimen has chlorphazimine in it, so the difference is chlorphazimine. Now, when the treatment starts, you see both arms, you see the reduction of colony-forming unit, but at the end of 2 months, injectable stop, then the control regimen was not able to get rid of bacilli. The experimental regimen has chlorphazimine in it, completely got rid of the bacilli. So you can see that this is the, you just see some tiny bacteria there, and here it's completely clean. So that's, I think, provide evidence for me is quite convincing that chlorphazimine is something that perhaps we miss in the past. We kind of neglect the utility of chlorphazimine for such a long time. Then isoniazid and prothionamide. He told me that he's designed that in a way of complementary. We know that high-level resistance to isoniazid caused by CATG gene would have remained susceptible to prothionamide. And you have low-level resistance, so isoniazid resistance due to INHA mutations, then you also have close resistance with prothionamide. So those are issues that he put these two together and then increase the doses of isoniazid. So hopefully that could be useful combination to overcome and to help the core drugs, that is the quinolone and injectable in the intensive phase, perhaps also pyrazinamide and other drugs in the intensive phase. So you see, in most countries, the prevalence of resistance to prothionamide is not really high, about 10%, 20%. And perhaps it's one of the best bactericidal second-line drugs from the paper by their systemic review about 9,000 patients coordinated by Professor Dick Menzies. In that analysis, prothionamide is the only drug that consistently shows the association between that drugs and favorable outcome. And in cycloserine and PS, we didn't see that. So perhaps that is the unique aspect of prothionamide. It is used in intensive phase because we know that prothionamide is going to cause, gastrointestinal intolerance. Patient will not be able to tolerate that. So because used only in intensive phase, and in the continuation phase, you will need some drug to help quinolone, and that would be chlorphazimine. Close resistance with isoniazid is an issue, but how important it is, perhaps we do not really know, but then the issue will need to link with isoniazid. The people ask, why do you insist using isoniazid? There's a clinical trial in the past showing that if you use high-dose isoniazid in the treatment of MDR-TB, the patient are more likely to convert it to negative, and they have spleen conversion much faster than those who do not have isoniazid. He used two papers to illustrate the point of isoniazid. This is a paper published in 1999 showing that the serum concentration of isoniazid in fasting or high-fat meal, you see that peak and then going down. But then the MIC over that is the MIC of INHA mutation, low-level resistance, and this is wild type. So you can see that the isoniazid still can overcome and cure and help the treatment of MDR-TB because it's above the MIC of INHA mutation and also wild type. But when it comes to high-level resistance, he used this slide to illustrate that now the susceptibility testing that we have is using one breakpoint. Below that breakpoint, we say susceptible. Above that breakpoint is resistance. But perhaps what is needed is really an MIC to tell us the mutations and how the mutation will affect the treatments in a quantitative manner. Yes. Okay, so you see that this is the wild type, this is distribution of MIC, and this is INHA mutation, this is MIC distribution. Here is the critical concentration that we use in the lab to decide, and here is the drug serum level. So, and here's wild type distribution. So you can see that the serum concentration of isoniazid, in fact, is quite high. It can overcome low-level resistance, but perhaps also some moderate level and high-level resistance. So isoniazid, in his mind, is always included a high dose. So he showed that if the CAT gene mutations, some of those, majority perhaps is at this level of MIC, and then peak serum level is similar to peak serum level at low dose if you only use 300 milligrams. If you use high dose isoniazid, you double in the peak, and triple, you go even higher. So it means that you go higher. So in the stream trial, we use even higher dose of isoniazid. It's not a cold drug. It's mainly to help the cold drugs. And also, we know that now you use a gene expert. You have no rifampicin resistance, maybe isoniazid remains susceptible, so the regimen will still work for those type of patients. So I think this last slide has stopped here. Thank you for your attention.
Thank you very much. Let's skip a little questions and move to the next one. Yeah.
Thank you very much, Senyuan. Can I call Dr. Ong? Dr. Ong is from Bangladesh. So he's from the country where this regimen was discovered, and he was part of the team with Armand Vanden, and he was the first author of the paper that Senyuan showed just before with results for 500 cases in Bangladesh. We have updated data on what's happening in Bangladesh. Thank you.
Thank you, sir. Good afternoon. Thanks to the organizing committee for giving me scope to share our updated findings. I would like to remember our greatest scientist who developed this shorter regimen. And also, I would like to thank my colleagues, our patients, and our supporters from Damien Foundation Brussels, Institute of Tropical Medicine, the Union, and our ex-colleagues like Dr. Salim, Dr. Paul, etc. And also, I'd like to thank other colleagues who tested this shorter regimen, which led to the WHO endorsement for using this shorter regimen for MDR-TB patients. So this is just an update. Which one? So there is no conflict of interest. And we published in December 2014 outcome of more than 500 patients, and this update is more than 700 patients, included till December 2013. So this is an observational study starting from 21 to 9 months, which already Chen has explained. I think skip this. So from March 2005 till December 2013, total 815 patients were enrolled under this shorter regimen. And we excluded 108 patients as there were 16 patients non-tubercular mycobacteria, 92 had no proof of MDR, that means rifampicin isoniazid were not resistant combined. So total 707 patients were retained for this analysis. And we used the treatment definition outcome proposed by Lessersen and collaborators, as this was shorter regimen, 9 months. So we have to include actually post-cure follow-up also to fit in this definition. Out of 707 patients, actually 589 success, that is 83.3%, and loss to follow-up was 55, died around 7%, and failed was also low, 2.3. And out of these 589 patients, after 24 months post-cure follow-up, only 5 relapsed, which is less than 1%. So total 16 failures, among them actually all 15 had high fluoroquinolone resistance, including 1 primary XDR. And only 1 was susceptible, and this patient failed because of irregular treatment. And 5 relapsed, 3 of them had high level fluoroquinolone resistance, 1 low level, and 1 was susceptible. Actually, as mentioned by Chen in last presentation, we tried to reduce the duration of injectable like category 2 DSTB to 2 months. 30 patients received kanamycin for 2 months, and out of 32 failed, which shows 7% actually failure rate. And we stopped actually. And out of remaining 671 who received 4-month kanamycin, there are 14 failed, which is around 2%. So reducing kanamycin duration increased the failure rate, though the number was less there. Post-cure follow-up, out of 589, actually 540 completed 12 months follow-up. Out of them, 24 months, total 2 years follow-up was 497, 36, 18 months, and 7, 12 months. And out of these 5 relapse during this post-cure follow-up period, 1 relapse after 2 and other 2 within 6. That means actually all these 5 relapse within the first year of follow-up. The 13-month follow-up, actually the follow-up was delayed. It was supposed to be done by 12. The patient was delayed. Treatment duration, almost the same as it was published in 2014. That maximum patient completed 9 months. And for 13% patients, we needed to extend intensive phase by 1 month. And only for 10%, intensive phase prolongation was required by 2 months only. Adverse events, relatively few. Actually, there were no adverse events for 74% patients, and only 1% had hyperglycemia. And ataxia or hearing loss also very few, 4%, 1%. Kanamycin dose had to be reduced for 6, and for 1 we had to stop kanamycin. And there were minor events, mostly vomiting, arthritis, neuritis, etc. But the proportion was not that high. This we know amplification, as already mentioned, there were no acquired resistance of fluoroquinolones. So actually, we are presenting a large cohort of patients comprising more 107 patients, proven MDR-TB cases. Quinolone has been the core drug of this regimen, and low-level initial quinolone resistance could have no influence on favorable treatment outcome. Even high-level fluoroquinolone resistance had 50% chance of cure if there was no pyrazinamide resistance. Modification, that means prolongation of intensive phase, still better chance. And advantage was decentralizing in the field conditions, and also there was no exclusion criteria, for example, age or DST or serious morbidity. And we know that in HIV prevalent settings, other colleagues tested this, that this works well. Efficacy is still maintained with higher number of patients and almost similar to the first line, despite increasing quinolone resistance. Minimal resistance amplification. I think this was, thank you.
Thank you, Dr. Wang. Dr. Ong, you were quick as a short-course regimen. So I suppose we can take one or two questions in the audience.
Question? Question?
Yeah, what question?
In the back.
One.
There's a roving microphone. Yes.
I'm Inge Koppelaar, working in South Africa, where we are soon planning.
Can you speak closer to the microphone? Yeah.
Nope.
Anyway, my question, I'm working in South Africa, where we are soon planning to roll this out. My question is about the dosing of the kanamycin. We have had discussions because our clinical setup, it won't be suitable to give kanamycin 7 days a week because clinics are not open. So my question is, what should we do if we are only able to give it 5 days a week? Should we extend it then and make it up to 120 dosages, which I guess from 4 months? Or what would your advice be on that?
Thank you. Actually, we use daily, that means 7 days during the past 3 months. Then 4th month onwards, we use 3 days weekly. And for patients experiencing adverse events, we use 3 times in a day, in a week. That means I think for your situation, 5 days would be sufficient. Yeah. Please.
I think injectable is very important in the intensive phase, especially in the beginning, the first month. You go for, if you can do every daily, it would be better because the role, when you have a high vascular role, you would like to have an injectable to help quinolone. So the point is not to 120 dosage because when you go into sputum conversion, it's not really important. So what is important is hopefully that you can get daily at least 1 month, and then hopefully 6 days per week, and not quickly go for 5 days to begin with. That would be kind of the spectrum of risk, I guess, of failure. Yeah.
So one more.
Tine de Meulenaar from Damien Foundation. I saw in the first presentation that proteolamide resistance was not making a difference. Yeah. Did I read that right? And I hear from my colleagues in several countries that proteolamide is the one medicine that people really, really find the most disgusting. So you try to shorten kanamycin, but is it an option to try to shorten proteolamide?
Would you like to answer or let me? Okay, thank you. Actually, we didn't show here our observation, but Chen already mentioned that proteolamide is a bactericidal drug. And this works better during the intensive phase when bacterial load is high and we use maximum number of drugs to reduce the bacterial load. And from our observation, as you mentioned, proteolamide is a gastrotoxic. Almost all patients suffer from vomiting and like this. So in our observational study, we initially used proteolamide throughout the treatment. And we experienced higher default rate because of these gastroenteritis side effects. Then we reduced to only intensive phase. And we used later on in all these shorter regimens, only in intensive phase. And we observed still better.
Okay.
Yeah.
So we're going to take one last one and move on to the next presentation.
First of all, congratulations. Really very exciting and wonderful. So I want to ask him a question about the programmatic elements that supported this, because it's extraordinary that there was such a low default rate or dropout rate, and also how adherence levels were maintained during the course of this. Even though it's shortened, it's still a substantial amount of treatment and a lot of toxicity. How are you so successful in terms of keeping people on treatment over the period of time of the course of therapy?
I'm not clear, actually. Could you please repeat? It was not clear.
How were you able to keep the persons taking these drugs for such a long time with the observations, the low default rate that you had? You must have done something to incentivize individuals to keep staying on the drugs.
Actually, in our setting, we have good relationship with the patients. During hospital period and also at the field clinic, we give health education to the patients, inform them so that they adhere to the treatment. And initially, we did not have any incentive, anything, but later on, since 2013, we received this incentive, that is financial support to MDR-TB patients. But we didn't observe actually any change without and with incentives.
Thank you very much, Dr. Ong. The next presenter happens to be, so as you can see, Dr. Trebuch has two roles here. He's co-chairing, and he's going to give the third presentation, summarizing the result of the Union's observational study using the 9-month regimen in Africa. The floor is yours, sir.
Thank you, Ken. Thank you, everybody, to be there. So it's impressive to go after the Bangladesh who opened the way for the world. No conflict of interest. Just a short, very short background. So as everybody knows, until May 2016, WHO recommended regimens for the treatment of MDR-TB. Very long, 20 months, low cure rates, less than 55%. 2010, Van Den with Ong and Salim reported 88% cured without relapse in 206 patients treated with a 9-month regimen in Bangladesh, which is well known. Reaction International, very skeptical. That's not possible. That's too good. So we launched a study in Benin and Cameroon for a 12-month regimen because we didn't dare to go to 9-month regimen considering the opposition at the international level. And we did this survey with this study, so in these two countries, and we had excellent results. So we convened another workshop with 9 countries coming and proposed the 9-month regimen from Bangladesh, and the 9 countries said, we go for that. So we launched this observational study in 2013 to determine the effectiveness of the 9-month regimen, same as Bangladesh, with some little differences. One is gatifloxacin was replaced by moxifloxacin because the problem with gatifloxacin, with the dysglycemia, which seems to be not a problem, but the manufacturer stopped to do the gatifloxacin in some countries. So we thought it was safer to use moxifloxacin instead of gatifloxacin. Also, we use moxifloxacin at the normal dosage, 400 milligrams for adults. And we want to document adverse drug events. So 9 countries in Francophone Africa, it's easier to share the data when we speak the same language. Benin, Burkina Faso, Burundi, Cameroon, Central African Republic, Côte d'Ivoire, DR Congo, Niger, Rwanda. The study was conducted within the frame of the National Tuberculosis Program, and there was no incentives for the patients, neither for the health workers involved in this study. We really are quite glad that after the study, it went on, as it was before the study. All patients with rifampicin resistance confirmed by molecular or phenotypical tests were included, except those aged less than 18 years old, those previously treated and declared to be treated with the second-line drugs, and pregnant women. We tried to really do directly observed treatment throughout all the treatment. Try to do it as strictly as possible. So we had a follow-up, monthly clinical, biological, and bacteriological, smear and cultures, during all the treatment, and also every 6 months after the treatment. DST was performed on initial strains and on strains isolated at 6 months of treatment and later. These were also sent to supranational laboratories, Antwerpen, Milan, for further analysis. That was in the protocol. We had some difficulties to send these strains. There was the Ebola epidemic. To send material from one country to Europe at this time was forbidden. Even when it was killed bacteria, the airplane company didn't want to take the specimen. And we missed a lot of control from the supranational laboratory because of that. So every patient with rifampicin resistant satisfying the criteria for inclusion were analyzed, and out of 1,028 patients that we received, 22 were excluded because we had no proof of resistance to rifampicin. Perhaps they were resistant also, but we have no proof. So results are presented for 1,006 patients who satisfied the inclusion criteria. So the study population, 34 years old, female 34%, what we find usually in this country for sensitive TB. Lots of failure of category 2, so patients who already had received the treatment before, and failure also for category 1, so first-line treatment. 23% relapses, 14% new cases, 5% others. Patients were quite heavily affected, with 64% had more than 50% of their lung with images on the X-rays. HIV positive, we're in a region which is quite high. 20% of the patients were HIV positive. And the median body mass index was 18. Smear and culture conversion. As you see, and what is common also with the sensitive tuberculosis cases, we have the conversion for cultures arrive sooner than the conversion for smears. And cultures, I must say, is always very difficult to obtain and to perform in the country, but that's perhaps another discussion. Anyhow, at month 4, we had 88% were negative for the by cultures, and 82% were negative by smear. Treatment outcome, 73% cured, 9% treatment completed. That makes 82% success. We were happy. That was what we expected, and we found it. Failure, 5%, dead, 8%, lost to follow-up, 5%. We use the definition of the 2003 WHO guidelines, where cure is treatment termination without evidence of failure and 3 consecutive negative cultures after the last positive results. So you use 5 even in Bangladesh at this time, but now it's only 3. And failure, any positive culture at 6 months or later, except is preceded by more than 1 and followed by more than 2 negative cultures. Good results. Success rates according to initial resistance. So, of course, the problem is what is the bacillus resistance at the beginning. INH, no difference between susceptibility at the beginning or resistance at the beginning of treatment. As you see, most of the patients were resistant to INH. The criteria for inclusion in the study was resistance to rifampicin, not rifampicin and INH. But success was the same, almost the same, if it was susceptible or resistant. Fluoroquinolone, as shown by Ong before, problem and by Senyuan also, susceptible have much better success rate, 82%, than those who are resistant. We didn't find in this study what is shown in Bangladesh, that the low-level resistant were as the success rate was similar to those who were susceptible. But the numbers are very, very low. only 4 cases, so we really can't say anything. Second line injectables, we have 81% success among the susceptible, 67% for the resistance. Quite a difference, but it's not statistically significant. Pyrazinamide, very interesting and controversial because that's not what we found in the other country, in some other studies. Susceptible or resistant, you have same cure rate, exactly the same cure rate. For information, all these exams for pyrazinamide were performed at the ITM laboratory in Anvers, so I think the results are not questionable. Thank you, book. Risk factors for failures. Risk factor is what we could imagine at the beginning. More risk factor if you have resistance to fluoroquinolone. 29% failures among the resistance, 5% only among the susceptible. Very, very significant. The relative risk is very important, 7.1. No other significant statistically difference for resistance or susceptible for second-line injectables, INH, or PZA. Also, very interesting, HIV, body mass index, extension of the disease, part of the lungs were affected by tuberculosis. There was no statistical significant difference for failures, neither for success rate. Amplification of resistance. We had, out of 565 initially susceptible strains, 11 turned resistance, 1.9%. All were resistant to INH at the beginning, and 1 to second-line drugs. It's a problem. I don't know if that's too much or not too much, but that's a real question. Should we use 400 milligrams, as we did, or should we go for 800 milligrams? Probably better to go to 800 milligrams to try to avoid the development of resistance. Second-line injectables, 772 at the beginning, 7 turn resistant, 1.2%. Also, I forget to say there was only 1 HIV cases among the 11 to turn resistant for fluoroquinolone, and 0 among the 7 who turn resistant among the 7 second-line injectable drugs. INH, no one of the 95 turned resistant to INH who were sensitive at the beginning. Outcomes according to HIV status. Less success rate, 72% among the HIV positive, 84% among the HIV negative. That is due to the dead. Much more patients die when you're HIV positive than you're HIV negative. Same thing among the sensitive patients. And if you take out the dead, the success rate is the same among HIV positive and HIV negative. The median time to death was 63 days for HIV positive and 59 days for HIV negative. We look at that because usually we say, okay, the HIV positive patients, they die much quicker. In fact, in this study, no, same time for death. That's a Kaplan-Meier survival curve where you see the result for the HIV negative and the results for the HIV positive. And you see very quickly the decrease of the success of the survivors among the HIV positive. We also looked at the adverse events and biological abnormalities during the monthly visits to the health centers. And there is a lot of numbers, but we graded the adverse events according to the ANRS scale, which have 4 degrees, which is quite common. And the 4 degrees is very serious. There is life-threatening menace. And the 3rd is very important, also very severe. Gastrointestinal, very common at the beginning, not very serious. but always disagreeable for the patient. Neurological, hepatic, renal, joint pain, not too much, very rarely severe side effects. Hearing loss is a real problem for us. We had 5% grade 3 and 3% grade 4. Hearing loss is really, really an issue related to kanamycin for sure. There was no severe cardiac adverse event reported. QTC was not significantly prolonged after 1 week. One slide on hearing loss, patient categories, new case or retreatment case, more problems of hearing loss among the retreatment cases, 5% than among the others, 2%, but it was not significantly statistically different. Audiogram at baseline, also more if it was abnormal at the beginning than those who were normal, but it was not significant. HIV status, much more problems with hearing loss among the HIV positive. We don't know why, but it was a constatation of the study. These data are made from an audiogram that we had at month 0 and month 4, so we can compare really according to the objective results. You know. Conclusion, high success rate in this study, 82% with limited adverse events in NTP conditions. Very similar success rates in other published studies. Bangladesh, we've seen 83%, Niger, 89%, Cameroon, 89%. So we fully agree with WHO treatment guidelines published in May 2016. It's time to widely implement this 9-month regimen for rifampicin-resistant TB when resistance to fluoroquinolone and second-line injectable agents is considered highly unlikely. In this country, it is highly unlikely because less than 5% of the patients are resistant to fluoroquinolone. This regimen probably could be used for more than 95% of MDR-TB cases, excluding pre-XDR-TB, pre- and XDR-TB. That's the principal actors of this study. Thank you very much for your attention.
Thank you. I myself could have about 4 questions, but we're gonna, in the spirit of time, we're gonna ask you to hold your questions until the discussion. Write them down. Let me invite Philippe Ducros to give his presentation shorter and better with a question mark at the end. And he's presenting results and challenges from a simplified short regimen in Karakal, Pakistan.
Thank you very much for the honor to present here. I'm not sure whether the title shorter and better refers to me or to the results. You can make that decision at the end. I've always just wanted to get up and say that. But I think what you'll see, you've heard some very promising, very exciting results, and there always has to be one person who's the bottom kid in the class, and that's me. So let me present what we've found. Obviously, the WHO data that's come out recently has shown a huge gap between the number of cases and those getting to the end and successfully treated. And our patients are asking us for something that is much better and much better tolerated than what we currently give. And this led us in Uzbekistan to try something different, but to also try and get some better data on this short course regimen in a different setting. So what I want to do today is 2 things. I want to present the interim results from this ongoing study, and then also just talk about a few reflections for scale up from our experience. So the setting that we've been doing it in is very different from what's been talked about. MSF has been working with the Ministry of Health since 1998 and implementing a drug-resistant TB program since 2003 in this western area of Karakal, Pakistan, in Uzbekistan. It's an area that has 23% of MDR in new cases, so very high rates. In that DST survey from 2011, there was 7.9% of fluoroquinolone resistance in the MDR cases and 18.9% of kanamycin resistance. And then also what we see is that ethambutol rates and pyrazinamide rates are over 70% in the western part of the country where we work. And our success rates overall are 57%, although if you pulled out a group of patients who'd never been treated before, who didn't have resistance to second-line injectables or fluoroquinolones, then we did get a success rate of 74%. So just keep that number in mind. So what I want to talk about is this prospective single-arm cohort study that we used a modified short course regimen based on the Bangladesh regimen. And it was recruiting between 2013 and May 2015. All the patients I'm talking about today have completed treatment. Some of them are still undergoing follow-up. We won't get the last patient through the 1-year post-follow-up with cultures until February 2017. This regimen looks similar. The key differences, there are 3 of them. Firstly, we started all patients on capreomycin because of the underlying second-line injectable resistance rates. So in our study, if you were resistant to kanamycin, that was not an exclusion criteria. We actually continued them. We switched to kanamycin if there was confirmed sensitivity on the DST. We also used moxifloxacin, but at standard dose, not at a higher dose, so 400 milligrams. And because we didn't know how it would work in a setting with high second-line drug resistance, we also continued prothionamide throughout the continuation phase. So we implemented this 7 days a week, including 7 days a week injectables. We had ECG monitoring, and we made use of molecular tests, both GeneXpert and the Hain second line, which was version 1 at that stage. And we're doing a 12-month follow-up. So the inclusion criteria, patients actually with rifampicin resistance, but almost all of them had MDR-TB. If patients were younger than 14, they could be included on the basis of a contact histories DST rather than the patient's DST, and they required informed consent. The main exclusion criteria is patients who were critically ill, patients who had resistance to ofloxacin, either on culture or on the molecular test, patients who had resistance to both kanamycin and capreomycin, and certain forms of extrapulmonary TB. So I'm going to walk you through the kind of cascade of our enrollment process, because I think there's some lessons we can learn from this. So we screened 351 patients in this context who potentially had MDR-TB. And you'll see here that 146 ended up being enrolled, around a third, and 205 were excluded. And I'll go through those in a minute. But the other key thing is that in this context, the overwhelming majority of patients were started on ambulatory treatment from day 1, so not hospitalized. So the key reasons for exclusion, you can see that there is a large range of reasons, but the key reasons fell down to really 3 key things. So about a quarter of patients, this is numbers at the top, not percent, about a quarter of patients had a history of second-line drug use for more than 1 month. Another quarter of patients had additional resistance to ofloxacin or dual injectables. And then there was another quarter of patients who either we lost to follow-up, we couldn't find them between when they'd sent a sample and when we tried to get them on treatment, or they did not give consent. So patients had the option to choose to have a standard regimen, which we found was something that happened quite a lot. At the start of treatment, when we first started this study, people were skeptical about being guinea pigs for a study, but very quickly the word went round that you could shorten your treatment, and then people started asking us to be on the study. So Of those who were enrolled, we had a further 18 patients who met exclusion criteria after they'd started the short course regimen. So these patients I've excluded from the analysis, but I'm going to give you a little bit of data around how do these patients do in the program, because I think that's an important question as well. Do we do harm to patients by giving them maybe a substandard regimen for 1 or 2 or 3 months while we're waiting for DST? So of these patients, we had 3 patients who did not have rifampicin resistance, and we had 15 patients who had pre-XDR or XDR. So from those patients, you can see here that there were 10 patients who had resistance to both injectables that we tested for, and from those patients, 5 have been cured, and I guess I wanted to make the point that for 2 of those patients, when we got the DST back, they were clinically improving. They actually elected to remain on the short course regimen, even though we've withdrawn them from the study results. We can debate whether that was the right thing to do, but sometimes patients said, if you're going to extend my treatment, I'm not going to take anything. So we kind of felt in a bind and had to commit to keep doing that. But I guess the concern is also that we did have high loss to follow-up in some of these patients, and also 1 failure. This is also maybe part of my message, is that if you're going to be rolling out the short course regimen, you need to think about also rolling out the new drugs. So then we get to the bit you're probably most interested in. So we had 128 patients who met the inclusion-exclusion criteria, and the success rate overall was 71.8% in this selected subgroup. We still had quite a loss to follow-up rate of 10%, which in our context compares with over 20% in the standard 20-plus month patients that we treat. And our failure rate, and I'll come to what this is composed of, but actually quite high and a little bit concerning at 16.4%. So far on the relapse data, I don't have all the culture results yet. We're still waiting for some of those. But you can see here that we've got 79 patients, of whom 72 have been assessed clinically at 12 months, and there's no relapse yet. But not all of them have their cultures back. So hopefully we'll have more of that data in the next 6 months. We did a breakdown looking at outcomes by injectable resistance, so those who were resistant to 1 injectable but not to both, who still met inclusion criteria. And you can see here, although patients who had capreomycin resistance is very small numbers, only 2, for patients who had kanamycin resistance versus kanamycin sensitivity, we didn't see any difference. So for the failure patients, I guess there's a couple of points from this slide. Firstly, there were 4 patients who had a severe intolerance to, or had a serious side effect to one of the drugs, which required changing a drug in the treatment. And for us, that counted as a failure of the regimen. We also had 1 patient who became pregnant, 1 patient who then got diagnosed after starting treatment with osteomyelitis. So both of them, we also went to an individualized regimen, and they were counted as failure. So we had 15 patients who had microbiological failure, of whom 7 of them had amplification in fluoroquinolones or injectables. I don't expect you to read all of this. I think there's 2 key points, just confirming what was presented in the previous presentation. If we look at any side effect, and we were using the DAIDS grading, so some slight differences, but more or less the same, 4 grades. Overall, 78%, so the vast majority of patients had at least 1 side effect, but more than 75% of the side effects were grade 1 and grade 2, and there was only 1 patient who had a grade 4 side effect. In terms of QT prolongation, looking at the 1-month data, we had a median change. This is with the combination, I guess, of possible electrolyte changes, but also clofazimine and moxifloxacin at standard dose. There was a 21 millisecond increase with the median change. Interestingly, if we used the QTC of greater than 60 millisecond increase, we had about 6 patients, we had 6 patients at each time point early on, but actually they weren't the same 6 patients. And so using just an increase of greater than 60 milliseconds caused, I think, a lot of angst when we were rolling out the program, but the majority of these patients, actually, you were able to continue without making any changes, and they just got better. You just needed to check their electrolytes. So a few key thoughts on scale-up. In this setting, we enrolled 35% of patients, but if you include those who didn't give consent, those who didn't live within the area that we were doing the study, using our criteria, up to about 50% would be suitable or susceptible. I think given how much of a difference it makes to patients, then even if it's only a third of patients or a fifth of patients, I think it's still worth doing in our programs. And it really allows healthcare providers then to have more time for other patients, only because you've got shorter treatment. I think there's still a question about when best to start treatment. We started treatment based on history and when we had a molecular result. And then you saw those 18 patients who subsequently required a change of regimen. But in some settings such as this, there is the question, would it be better to wait until you had full DST and then switch patients to the short course regimen? I think in our setting, we're going to be going for a continuation of the strategy that we've already implemented. And then the question around what to do with resistance, with ethambutol pyrazinamide resistance. So just a reminder, we didn't use that to exclude patients. So these results include patients, a large proportion of whom had resistance to these drugs. I think the other thing when you're rolling out is thinking about how are you going to manage when a patient has a problem with one drug? Are you going to just switch that one drug? Are you going to stop it? Do you keep them on the 9-month regimen? In our setting, this counted as a failure, which led partly to the high failure rates, and we switched them to a standard regimen of 20+ months. I think this is something that should be looked at with further research, and we should keep a note of these cases. Also, clear guidance on how to easily manage corrected QTC at district level, I think, is important. And with our high loss to follow-up rate of 10%, with our high, albeit mild side effects, adherence support is just as important. It doesn't get any easier. You still need to apply attention to that. We had quite a few failures. So if you fail this regimen, you may still have an injectable that's working, but probably these other drugs, you're not going to count them as effective. So that kind of leaves these other drugs that I've listed there. The key point I wanted to make is, I think if you're going to roll out this regimen, especially where there's high second-line resistance, you need to roll out the new drugs and have them ready to be able to treat appropriately. So in conclusion, we saw good end of treatment and interim follow-up outcomes in this high resistance context with very low HIV. Rollout of the short course regimen, I think, requires also looking at your lab capacity and scaling up Group C and Group D drugs. And the adverse events and loss to follow-up argue about the importance of adherence support for patients. And acknowledgement to all of my colleagues, and Ministry of Health colleagues especially, and to the patients and the team in Uzbekistan.
Thank you very much for your intervention. Perhaps we will take the questions at the end of the presentation to run on time. Could I ask my friend Alberto Piubello to come for his talk? Alberto is working for Action Damien, and he is working in Niger since a long time, and he worked with short course treatment long time ago, and even he was also there for the 12 months study before the 9-month study. Thank you, Alberto.
Okay, thank you, Arnaud. Thank you for inviting me. I'm very glad to speak about the scaling up of the short course regimen because I'm a great fan of it. Actually, I started to treat patients in '98 in Cameroon with long 24-month regimen. And seeing the pain of my patients, I tried to take the second-line drugs on myself. And I assure you that the injection is very painful, that the proteonamide is disgusting. It tastes like gasoline, not to mention cycloserine and PAS. So I'm a great fan of 9-month regimen since the beginning. I have no conflict of interest to declare. As Arnaud and Aung have already said, the short course regimen was conceived in Bangladesh by Armand van Deun and the Damien Foundation and was implemented in 2008 in 3 African countries like Niger, Cameroon, and Benin with a more conservative approach because the patients were treated on 12 months. The data of Bangladesh weren't already available, and so the countries chose to have a more conservative approach because of the opposition of the international community. Actually, the regimen is spread in 9 African French-speaking countries, thanks to the work of the Union, the observational study presented by Arnaud. The stream trial is implemented in 4 more countries: South Africa, Ethiopia, Mongolia, and Vietnam. And MSF is implementing the regimen in Uzbekistan and in Swaziland. But some other countries are actually implementing the regimen, like Senegal, Guinea, Djibouti, Togo, I think also Belgium. And so we are really planning to scaling up. And if you know the beautiful movie of Michael Moore, actually we are planning where to invade next. Maybe you know this image of MSF. The old 24-month regimen consists in 14,600 pills. If we stack up the pills end to end, it's equivalent of the height of the Golden Gate Bridge, 228 meters of terrible and horrible drugs. The 20-month regimen decreased the number of pills of 9,000. But it's already equivalent to the height of Brooklyn Bridge in New York. The 9-month regimen is effective, is more tolerate, is cheaper, and it consists only in 2,400 pills for a patient with less than 55 kilos. And it's equivalent of the beautiful starry mosque of Mostar, 24 meters. It spans from the top to the Neretva River, built in the 16th century under the Sultan Suleiman the Magnificent. Why I chose this beautiful bridge? Because the height corresponded to 24 meters, and because it was bombarded as the short course regimen during years and rebuilt after the Bosnian War in 2004. So maybe the next conference should take place in Mostar. Okay, I will focus the main challenges of the implementing of short course regimen in 8 main areas. The screening and the diagnosis, the clinical training, the drug supply and management, the patient care, the bacteriological follow-up, the pharmacovigilance, the active drug safety monitoring and management, the recording and the reporting, and maybe just a few words about a shorter pre-XDR and XDR regimen. About the screening and the diagnosis, we should promote the gene expert because of the high predictive value of high positive predictive values in patients at high risk of rifampicin resistance. We should start the treatment without waiting for a confirmation in low-income settings and with difficult access to DST or to LPA. And the majority of countries applying the short course regimen actually have low level of fluoroquinolone resistance. The sputum transportation is a big challenge because the majority of low-income countries have few expert settings. And so we perform, in our country, we perform a system of transportation of sputum smear, putting the same quantity of smear and the same quantity of alcohol at 70 degrees, we can kill the bacilli. And so the transportation is easy and without complication. And actually in Niger and in other countries, we perform it by bus. The LPA should be implemented mostly in setting with high level of resistance to fluoroquinolone in order to put patients under short course treatment only if we have no resistance to fluoroquinolone or to the second-line injectable. The patient breaks the air with the resistance to second-line injectable fluoroquinolone or both should be put on the individualized regimen based on new drugs like bedaquiline or the lamanid. The clinical training is really important. Actually, the Union provided the first course on a short course regimen last April in Douala, in Cameroon. But the Damien Foundation, the Institute of Tropical Medicine of Antwerp, the Union has a great experience in short course regimen, and it can provide courses in English, in French, in Spanish, in Chinese, in broken English, and so. The aim of the courses would be the translation of guidelines in local context. Actually, many clinicians have many difficulty to translate the guidelines. For example, I feel uncomfortable to treat a pregnant woman with the 12-month regimens, with very toxic drugs like kanamycin, like proteonamide, and so the course is based on clinical experience of local clinicians. I think that it would be very important. And another key points maybe are the regular monitoring provided by external experts and the regular exchange between countries. That's very interesting in order to discuss the complicated cases. Drug supply and management. That's a very, very big challenge. I would like to stress 4 main points. The first one, the drug supply should be quantified yearly, but the order should be split in 2 orders per year to avoid preemptions. An emergency buffer stock should be provided for a duration of 6 months to prevent shortages. And to avoid a stock out at patient level, the drug should be delivered to MDR facility by kit at the start of the treatment. And another point about the clofazimine supply requires specific obligation, like a letter signed by the National Tuberculosis Program and the commitment to provide quarterly lists of patients. That's a complication. The Union performed this useful tool. Maybe it's difficult to see, but putting only the number of patients on the top and putting the situation of the stock, the tool calculates the quantities of every drug and the dates on which the order should be performed. Patient care is another key issue. The directly observed treatment is the key of for the success of the treatment and to the management of adverse events. The contact investigation is another capital point. Many patients at particular risk should be treated like inpatient, but wherever and whenever possible, we should promote ambulatory care. This is better for a patient, this is more cost effectiveness. The risk is the distance to travel and other costs for the patients. And so to promote the patient, the ambulatory care, we should stress these points, I think, to provide the free monitoring for adverse events, to provide free ancillary drugs to treat adverse events, to provide the transport fees from patients' home to MDR TB healthcare facility. That's a point, for example, for country assisted by Global Fund, because it's very difficult that the Global Fund provide this kind of fees. The nutritional supply is also another capital point, and the home visit to patients. The bacteriological follow-up, I put in yellow the minimal requirement to perform a regular follow-up for the patients put in a 9-month regimen. And so we should perform the sputum smear every month, and maybe 2 sputum smear at the end of the intensive phase. And if the intensive phase is prolonged to 5th and to 6th months, we should perform 2 sputum smears. And the culture every 2 months with a follow-up 12 months after cure. This is the minimal requirement to ensure a proper follow-up, a proper bacteriological follow-up. About the DCM, Arnaud has already explained that with the Union we have adopted the ANRS scale in order to grade the severity of adverse events in adults. The interest is to grade the adverse events in 4 grades of severity. The grades 2, 3, and 4 requiring a medical intervention. This is an example to ensure a proper follow-up of patients put in a short course regimen. The clinical assessment should be performed every month. The creatinine, the transaminase should be performed at start and at month 2. The audiogram at start, month 2 and month 4, possibly. The ECG during the first week at day 1 and day 7. The chest X-ray at the beginning, the pregnancy test at the beginning, and the HIV test at the beginning. This is the minimal requirement, I think. This is an example. I won't describe it, but this is an example that aids to follow up the patient and to grade the adverse events. And this is another example of a scale of instrumental examination and clinical sign. The main concern are vomiting. The most of patients actually vomit because of proteonamide. But these adverse events are easy to manage, providing a slight meal or giving metoclopramide 30 minutes before the drug intake, or giving ondansetron for resistant case. Pay attention, because if you give ondansetron, you should monitor the QT. The other main concern are the QT prolongation and the hearing loss. To monitor the QT, I think this is a useful tool. This is a little monitor which can be used by a nurse to monitor the QT. The QT should be manually measured and corrected in D2, V5, or V6. Be careful, because the QT varies a lot into the 12 leads. For example, is longer in V2 and in V3, more than 50 milliseconds. And the machine provides a result in real time and is very cheap, more or less $400. Be careful with the machines, because the QT is sometimes measured according to the Bayes formula. The Bayes formula overestimates the QTC. And so linear corrected formulas like Framingham, Hodge, or Fredericia formula should be used. And the QTC automatically calculated by the machine is the average over the 12 leads. That's not correct. You can have an overestimation. Another useful tool to monitor patients is this screening audiometer. And the screening audiometer may be used by the nurse in charge of MDR patients directly in the MDR facility. Why? Because when a patient complains of hearing loss, it's too late to reduce or to stop the kanamycin. And so the screening audiometer may identify mild ototoxicity. For example, a patient at 3 months with a mild ototoxicity, we can reduce the doses of kanamycin at 3 times a week. It's very cheap, with $100, and very easy to use. The recording and the reporting, this is this is not the last point, quite the last point. We need standardized tools, because they are the key element of the success of the patient treatment monitoring. And we should conserve a paper-based tools needed at peripheral level, like expert request, LPA request, lab register, patient's cards, MDR-TB registers, and quarterly report. The union can provide all these reports in French or in English in electronic format. And for sure, to have an individual database for MTBR patients. The last thing, this morning, I followed an interesting presentation about the NICST trial, but I have some concern about the doses of linezolid. So we should study some treatment with a maximal duration of 12 months with possibly less toxic drug based on bedaquiline, delamanid, and linezolid, and why not clofazimine, which is an excellent sterilizing drug. And so that's the end. Let me acknowledge my colleagues of Damien Foundation, the Union, the Institute of Tropical Medicine of Antwerp, because we succeeded in leading more than 2,000 patients from the Golden Gate to the Starry Most still alive. Thank you.
Thank you, Alberto. I wonder how you feel about the 24-month regimen. I was never clear about that. I really appreciate all presenters for having stuck to the time. And what you've witnessed is a presentation that provided the rationale for the construction of this regimen, an updated experience of in Bangladesh, followed by the additional countries in Francophone Africa, the use of this regimen in Uzbekistan, where the patterns of resistance are very different, and some of the challenges that we're now facing, very articulately done. I wouldn't call that broken English, by the way. So we're going to take questions from the audience. Please raise your hand, and I think we have a roving microphone. So I'm recognizing first Jerry, then Andrew. I see both hands.
Thank you all for a really extraordinarily exciting session and work. My question has to do with the issue of HIV and MDR-TV, because it involved one presentation, and it was somewhat concerning in that the rates were quite different. And so there are a number of questions related to that population. It's particularly important in the southern cone of Africa, where the HIV prevalence is so much higher in MDR-TB patients and actually represents the majority of the population. So it looked like the initial mortality fall off in the first 30 days or 40 days actually dropped very abruptly, and then there was a sort of parallel decline with the rest of the mortality. So it looked like it was an early mortality. And I wondered if there's information available on whether how severely immunosuppressed the HIV patient population was, how late they presented, what their CD4 counts were, and whether, in fact, antiretroviral therapy was administered before, during the treatment for MDR-TB in that population. And these are the issues that come up all the time in the patients that we care for.
Arnaud.
Yes, well, all the patients who were HIV positive were under cotrimoxazole preventive therapy, and almost all of them were under ARV. Also, we've shown only the median time between beginning of treatment and death, and that was equivalent. They were very similar between HIV positive and HIV negative. But I agree, when you see the survival curve, it seems it goes down very, very, very quickly. So probably some of these patients die very quickly, but the median time is the same. That's what I think. CD4, we have the information, but I don't have it with me. We measured it. Median CD4 was 200. Yeah, we will tell you that in the next paper we will write.
Be careful, because the peer reviewers are sitting here.
And the editor.
And the editor. Dr. Nunn.
My question relates to the dose of moxifloxacin. The recommended dose of moxifloxacin in the shortened regimen is the higher dose.
Right.
None of the cohorts have actually studied that yet. Arno raised the question whether the 400 milligram dose was sufficient.
Right.
And I know that some countries who are thinking about introducing the shortened regimen are actually considering introducing it, except not the higher dose. And I'd be interested to know what other people's expectation is, and indeed what the panel speakers have to say about the moxifloxacin dose. I think the concern is about the safety, because in fact there's no safety data, and we're not expecting any safety data until the STREAM trial reports early in 2018.
So any of the presenters want to comment on the dose of the fluoroquinolone that has been used? Philippe, you're jumping to the mic. Go ahead.
I'll give a quick comment. Obviously, with our results, with the failures that we saw, that's one of the questions. Is it due to the underlying resistance? Is it due to the fact that we used a slightly modified regimen with a lower dose of moxifloxacin? Is it because we started all patients ambulatory and maybe we could improve adherence? So I think in my own thoughts at the moment, because MSF has also been using this regimen in Swaziland, but also in a number of other countries where we often struggle to have the ECG monitoring and the capability to really do that well. Sorry, not in Swaziland, but some of the other more difficult contexts like Somalia. So we've erred on the side of, while there's no safety data, we will stick with the 400 milligram moxifloxacin. But we would love to have more data, and we're waiting urgently for when you publish your results.
Up front, please. You're getting your daily exercise here.
Thank you. Hi, Richard Garfield from University of California, San Diego. Really great presentations and very exciting news. I think Philippe raised this question in his presentation of whether or not to do second-line DSTs before starting the regimen and then waiting and switching later, or waiting for the results first. And I'm wondering, in areas where second-line drug resistance is not insignificant, what would people prefer to do, or what's the recommendation? Or do we need a study to figure that out?
I was accused 12 years ago of being a communist for suggesting that there's no excuse for not having DST.
So I think even if you have DST, even if you have a really good lab with everything there, you're still left with the question, do you wait for the full results, or is molecular testing enough? My own feeling is I think certainly for countries where the resistance to second-line drugs is low, I think we shouldn't be waiting until you have the labs all up to capacity, because I think we miss an opportunity. We should be looking to roll this out and as much as possible use this to also kickstart improvements in the lab that are very much needed. But I think in the contexts such as where we work, I think taking a good history helps limit a little bit. I think it just depends on as a clinician, your risk threshold around those patients that you are, if you choose to start when you don't have full DST results, some patients will get treatment that maybe only 2 or 3 of the drugs is working. My own preference would be, I think, to roll this regimen out rather than waiting a long time. And there was some data presented, albeit not a randomized study, showing quicker culture conversion when we compared in Uzbekistan against the standard of care. And so I think there is a benefit also, likely something in this regimen is helping get rid of the bacteria a little bit quicker, is my belief, and I'm waiting for more evidence to confirm that since it's a non-randomized study. So I'm more in the camp that would roll it out quicker, but I think some contexts need to be a little bit careful, and I think it's a country-by-country decision, really looking at not just the resistance data, but also the capacity of staff and lab.
Thank you. Did you have?
Yes, I have a question for Arnaud. I'm Lut Leijnen from the Institute of Tropical Medicine in Antwerp. Did you see a difference in the baseline resistance for fluoroquinolone between HIV and non-HIV infected patients?
No, there was no difference. As far as I remember, perhaps a bit less resistance to fluoroquinolone among the HIV-positive patients.
Hello, Judith Brochwell from Karolinska Institute, Stockholm. I'm just curious about studies substituting moxi for levofloxacin in the short course regimen, less cardiotoxic, easier to dose up. Have you discussed this?
I'm not a bacteriologist.
You might want to repeat the question. No, you don't need to repeat it. I think
okay. Levofloxacin, I'm not a bacteriologist, but what I heard, even in this, during this congress, is that levofloxacin is, even if it is a good fluoroquinolone, is not as good as the 4th generation moxifloxacin and gatifloxacin. And we went for moxifloxacin because we couldn't use gatifloxacin. Otherwise, we would have used gatifloxacin because that was the original drug in Bangladesh. But perhaps I want to.
Thank you. Actually, since 2015, when gatifloxacin was banned in Bangladesh, we replaced gatifloxacin by high-dose levofloxacin. Until now, our observation is, though we believe that levo is not
such potent as Getty, but our observation is, though there is delay in sputum conversion, smear both and culture, but it's not that inferior actually. And we hope to publish it maybe in the coming days. Thank you.
Thank you.
Sorry because it's
So
just to complete.
after you, I saw Dr.
Yeah,
Cabinero and then Dr. Mitnick. So
it's not a question, it's just to complete Dr. Ong. What you should know is that the high dose levo he's using is in the order of 1,500 to 2,000 milligram. So that's not what any one of you is using. So that might be as good as Gatti, but not 1,000 or something.
Very high doses.
Thank you. I'm Carol Mitnick from Harvard Medical School, and congratulations on the whole symposium. It was really interesting and very rich, and I appreciate the attention to thinking about programmatic implementation of that, because that's obviously what we're all ultimately interested in. To that end, I just had a couple of comments and a question. Phil, you pointed out nicely that the importance of considering this in conjunction with making new drugs available, and your point, I think, was mostly about people who don't respond to the short regimen. And I would just like to say that I think it presents an opportunity if we're adjusting guidelines in countries to integrate the shortened regimen. It's a good time to adjust guidelines to also integrate the use of bedaquiline and delaminid as needed. And I think we are at a really exciting point for MDR treatment where we may have great alternatives for virtually all of our patients. We're not quite there for XDR yet, although NICS is really, really encouraging. My question is related to this in thinking again about the eligibility assessment and the use of the best we have right now, rapid molecular tests, to rule out quinolone resistance for those who are going to get the shortened regimen. And I was struck by that 2% of resistance acquisition in the 9-country study. And it's not a huge percentage, but it was noteworthy that in I think all of the cases, or in all but one of the cases, the only other resistance that you documented was isoniazid. And I'm just wondering if anybody has insight on that, or thinking about what that means for how we screen to avoid additional acquisition of resistance on that regimen. And sorry, I just had one other point that I forgot I wanted to make, which was I also think the having much more data now is really helpful, and I'm glad to see this coming out. But there are a lot of comparisons and subgroups in the presentations we saw for which there probably wasn't power, or if somebody could speak to that issue. When we're saying there's no observed difference, in many cases we saw really wide confidence intervals around, not insubstantial effect estimates.
I want to answer.
So go ahead.
I fully agree with you, Carol, that the guidelines needs to be revised, particularly to include the 9-month regimen in the guidelines.
Okay, Pepe Caminero. My most important concern regarding the very recent WHO guidelines is, of course, the high dose moxifloxacin, addressed before. And the other one is, one of the exclusion criteria is the pyrazinamide resistant. Yeah. Theoretically, you have pyrazinamide resistant, and more than 50% of the patients with rifampicin resistant or MDR, they will have also pyrazinamide resistant. In SPY, we have not a very good DST. We have a not reliable DST. For the reason I like a lot your presentation, Arnaud, because according to your data with more than 1,000 patients, the pyrazinamide resistant susceptibility is practically the same, no? Because at that moment, most of the country going ahead with the shorter regimen, the problem is pyrazinamide. Because most of them, 50%, they have pyrazinamide resistance. And according to the WHO guidelines, pyrazinamide resistance is an exclusion criteria for this regimen. I think it's very important if we can speak about this.
Just to add, actually from Bangladesh study, we have seen also that 63 patients with pyrazinamide resistance among that 515 patients. And within these 63 patients, the treatment outcome 93%, much more than as you have shown that with the primary resistance, in your study also higher treatment outcome. In Bangladesh study also shows same actually. Yeah.
Success. Okay.
So I have actually one concern actually. Since the study actually what has been done with the getafloxacin, and getafloxacin is shown to be a very effective drug, is there any way to return it back, especially for the treatment of MDR-TB?
So we're going to take two last questions, one here and then Tom afterwards.
Thank you. Nimer Ortuño from Damian Foundation. I have a question for Alberto, actually. The 9 months regime in Bangladesh was based on population resistance. And in the WHO guidelines, we advise to do second-line LPA. And there are many countries that are willing to scale up the 9 months regime, but they are concerned about this indication. And also they are concerned because they have still drugs for the long regimen. And I fear that this is an obstacle, a barrier to implement this 9 months regime. I think here we have many representatives of the countries that they want to implement this regime. What will be your advice to them?
Okay, thank you for the question. To implement the LPA is very challenging in low-income countries. We started to do it in Niger, and we have many problems with shortages, with problems with machines. But we are in low-level quinolone resistance setting. For high-level quinolone resistance setting, I advise LPA, but making the difference with low-level quinolone resistance and high-level quinolone resistance. The regimen works fine with low-level quinolone resistance. And maybe this is an argument to increase the doses of moxifloxacin.
Mm-hmm. Mm-hmm. Tom Tang.
Thank you. Mine is not actually a question, but more a comment and an announcement. I know there are a lot of people here who are going to introduce the shortened course regimen in the near future, and one of the concerns is probably the availability of clofazimine, primarily because there's only one supplier. So I just wanted to let you all know that USAID, through its partners, has been looking at a potential manufacturer who is going to submit their product to WHO for WHO PQ and ERP next spring. And so if people are planning to start with the introduction of clofazimine at the short course regimen, clofazimine should be readily accessible by as soon as the ERP is achieved. Yeah, just for information.
Thanks. Well, thank you all. We are about 4 minutes over time, but it was very much well worth it. Thanks for your presence.